portal that's going into the liver, should be going into the liver, can be rerouted naturally. The liver stops taking that blood, it will be rerouted to the spleen. So we have to identify and recognize those type of processes that are going on, because there's complications with that we have to look for. It could even be that you look for the possibility of some remnant blood flow that's still there. That way they can do a procedure to prolong the patient's life just a little bit. So it's really important to understand how everything flows normally, and if there is a problem, like a disease process going on, what would be the next thing that we need to evaluate for, okay? So that's how, as a sonographer, the critical thinking comes in, and you have to know how to tailor the exam specific for that patient, what's going on with them, okay? And like you said, y'all were looking through, and this is a really kind of a fast look chapter. We kind of look through it and say, yeah, I recognize all this stuff, so you know it's going to be pretty easy to review it. Whoa, that's not tripping at all. Yeah, that's likely. We'll have to turn on my little handy dandy clicker. Alright, so actually, from the beginning, you know, when you were looking at the test you just took, the CAT scan, slide. When you're scanning the abdomen now, I know it's still really new. One goal to kind of keep in mind as you're scanning, try to think about those other structures and don't miss the forest for the trees. Sometimes you'll get stuff focused in, maybe you're looking at the kidney, okay? Or no, let's back up. Maybe you're looking at the liver and gallbladder. You saw on that CAT scan how closely related the right kidney is to the liver, right? Well, if we're scanning a abdominal study, it's a limited study, that means probably just gallbladder, take a few liver images, just kind of look around. A biliary study, looking to see if the gallbladder's got any issues. You'll see the kidney sometimes in your image, right? You can see the right kidney. So we're still going to glance at it, even though that's not what's ordered. You still survey through everything, okay? Were y'all here when Dr. Larison gave his lecture? Okay. Well, from a radiologist perspective, they're not going to want you to see if it is that limited biliary study, just to start taking pictures of the pelvis. Of course, that can't happen, all right? Now, if the patient says, hey, I'm hurting here, to make the patient feel better, you could just rub, the probe over that area. If you happen to see something, don't say anything at all to the patient. You could mention it to the radiologist, say, hey, do you want me to call the doctor and say the patient said their pain was low, do you want us to do a pelvic study? And then they would have to actually order that study. We can't just do it on our own. Does that make sense? Mm-hmm. But in that biliary study, because we see the right kidney, if you saw a mass in the right kidney, then take a picture of it with the gallbladder. You know what I'm saying? Include the gallbladder in the image. Include it in a gallbladder image. Okay? And then you could write on your report, incidental findings, blah, 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 whatever you saw. And they would still just charge for the gallbladder study, not the renal. But that would let their physician know, hey, we might need to order something else. Or you could, like I said, ask the radiologist, do you want me to call them and see if they want to go and order it while the patient's here? See what I'm saying? But we've got to think about all these other structures, how they work together, if they're involved with one another at all, okay? And don't miss the forest for the trees. Don't be so focused in on one thing that you don't see the whole picture. Okay, I think that's the biggest takeaway from this chapter. is, you know, you've got little pieces of the puzzle. You want to imagine the whole puzzle put together. Okay? All right, it starts out, we're not going to go all the way back to the chemistry and the makeup. It goes all the way back to the beginning of the chapter. Tells us that, you know, everything's made up of atoms, and atoms join together to form molecules, and molecules join together to form little organelle or cells, and the cells join together to form organelles, and organelles to organs, and the whole building block. Okay? So it takes us back that far just in an introduction. But there is one thing that you can gain from this, like right here, this middle little bullet. There are 4 main types of tissue: muscle, nervous, connective, and epithelial. So you're going to hear the word epithelial. There's epithelial tumors. The epithelial is usually a lining or a covering over something. Okay? So if it's an epithelial cell tumor, then it comes or is derived from those cells. So understanding what the epithelial means, you know what a muscle is. So like what they're saying is like the heart. It's mainly a muscle, right? Then there's connective tissues, there's nerves. So like the uterus. The uterus is mainly a muscle, right? It's a hollow muscular organ. The myometrium is muscle. Okay? And then you have the body system. So you have these organs, but they work together in concert. And if one starts messing up, it can tend to snowball and affect the other organs. So that's, again, to me, the biggest takeaway from this chapter is, yeah, I know the liver, what it does. I know the spleen, I know what it does. I know the pancreas, I know what it does. Do you put it all together and cohesively think, you know, this is how it all flows? For instance, say the blood. Do you remember where those worn out red blood cells are taken apart? I got to close this because I can't hear y'all because of them. What now? The spleen, right. So, where's the red blood cells made? In an adult, not the baby.
No.
Well, the baby is the liver mostly. But with us, it's our bone marrow. Okay, so hematopoiesis in a fetus, they don't have bones yet, so it's the liver, and mainly. The spleen and the liver make all the blood, okay, in the fetus. And they can take over that over again in dire need. So they can beef back up and start trying to produce red blood cells if they have to. Excuse me. I got off on the track of what. Okay. So understanding that the spleen is going to decide, hey, this red blood cell has met its life expectancy. I can't polish it up and send it back out anymore. We need to just scrap it. It's kind of like scrap metal. You know, it's going to take apart the pieces. And somebody in Marathon, Florida really wants to get in touch with me. I have no idea that. But it's going to take out anything it can use, like iron, okay, and use it to make more red blood cells, right? And then the byproducts it'll even use, it's like a recycling station. The bilirubin and biliverdin are going to be sent to the liver, and bile's going to be made out of it. So understanding how all this kind of works together, not just separate little compartments. And that's, from my recollection of college and high school, learning anatomy, it was real compartmentalized. It was more, hey, we're looking at the liver today, and then you move away. You don't really, I never did, put all the pieces together until I started in ultrasound. So that, going forward, you're going to have 3 more quarters of abdomen, OB/GYN, and vascular. And in abdomen, you're going to get a real, in all of them, you're going to get a refresher for the anatomy and physiology, but really try to start focusing in on how it all cohesively joins together, because you're going to be alone with the patient one day, and have to use those critical thinking skills to put the pieces together. Hey, this is what's going on. These are their labs. This is what the doctor thinks is going on, and this is what I see. Okay? It's kind of like a mystery novel ever unfolding. You might get a little piece here, a little piece there, but you got to put it all together for the whodunit part, or what's going on part. Okay. Any comments, concerns, questions? Any of that? Does it make sense what I'm trying to tell y'all? I'm the kind of person, if I kind of know going into something that I'm studying, why I'm studying it, or what I need to get out of it, it sure does help me learn, in the learning process, versus just spinning my wheels, not knowing what direction to go. Okay, so you've got to be familiar with the skeleton and muscles, respiratory, nervous system, but just familiar, okay? Unless you're going into musculoskeletal, you probably don't need to know the inner workings of the shoulder like the back of the head, okay? Now, if you're going into musculoskeletal, yes. Rotator cuff, they've started really looking at that with ultrasound now, things like that. But, knowing that there's 2 bones in the lower limbs, that's going to be important because you don't want to be scanning an OB. I can't tell how many times that people will measure the humerus or the radial bone, radius, is that what it's called, and call it the femur, or they'll measure tib fib. I'm like, there's 2 bones there, so that can't be the femur. Okay, that's the lower leg. So things that you already know, little things that you might take for granted, are going to help you when you're scanning that fetus. If you're lengthening it out, it's an appendage. If there's 2 bones, that's not the one you want to measure. We only measure the femur. Now, if there's a suspected skeletal dysplasia, like a dwarfism, something like that, then we measure all long bones. But just when things are looking normal, we only measure the femur. So we need to make sure we're on the femur, right? Okay. So as far as the skeleton goes, that's about as far really. That and the cranial bones. We need to understand there's an frontal and occipital, okay, and parietal bones, because you're going to be making a measurement called the biparietal diameter. So it means you're going to measure from one parietal bone to the other parietal bone. So you don't want to do that, occipital frontal. There is an OFD, but if you're saying it's the BPD, and you've got your calipers on the OFD, how silly will that be? Right? So knowing the bones is important for some of them. You don't have to know all 206 or how many there are. There are bunches. Okay. Muscles, the musculoskeletal system. Muscles will probably be the more important. For instance, does anybody know what muscle is posterior to the kidneys? That muscle? The psoas. Okay? You can actually see, that they go vertically, right from the spine down into the pelvis. Okay. Those are ones that you'll want to know. So when you're looking at the diagrams, not everything on every diagram is something you need to commit to memory. Okay? But you'll read, when you get to the kidneys, you'll read in the book that you can visualize the kidney move with respiration, and it looks like it's sliding up and down on top of that stationary psoas muscle. Okay? So if you turn in transverse, if the muscle is like this, lengthened out, it's going to be long when you're scanning the kidney, because it goes up and down vertically in the body. Okay? But what about when you turn transverse on the kidney? It's going to look like that. We don't want to call the psoas a mass, right? So we need to know it's there. Okay? So that's what they're talking about. Understanding not every muscle in the body, not every bone in the body, but the things that surround the organs, the soft tissue organs that we're going to be scanning, we need to know. Remember when I showed y'all that the left lobe of the thyroid gland. What did I point out? I said, now this is between the trachea and the left lobe of the thyroid gland. Don't get it confused with a mass. Do y'all remember? The esophagus. Remember? Because if you didn't know what it was, you might think, oh, what's that? So, structures like that, you will want to pay attention when you're looking at the anatomy, the new anatomy that you're learning. Remember, don't miss the forest for the trees. You're focusing on that tree, that thyroid lobe. Look around it. Anterior to the thyroid lobes, there's the strap muscles. You remember I pointed to those and said they can shadow out sometimes. Knowing what those are. And if you forget, maybe it might go 6 months when you first get your first job. It might be 6 months between thyroids. I mean, you never know. It might be every day, but it might be a long span. Keep your book handy, okay? If you see something, we're always going to turn on the long plane and the transverse plane to evaluate it, right? So just keep that kind of thing in mind. Put color flow on it. Does it have blood flow in it? You know, that might help you identify what you're looking at, okay? The remaining systems, the endocrine, digestive, circulatory, lymphatic, these are the ones that we have to thoroughly understand. Let me do my little red thing. Thoroughly understood by the sonographer. Thoroughly. Okay? In repro, y'all been studying about the menstrual cycle and the ovarian cycle. Okay? You get caught up in, okay, the endometrium. Wow, I gotta find it before I can figure out what it's doing. Okay? But if you will pay attention, even ask each other, when you start scanning somebody, are you on any kind of hormone therapy, like birth control pills? Okay? If the patient is on birth control, would you expect to see proliferation? Have y'all gotten that far yet? You won't see proliferation of the endometrium. So the menstrual cycle, what happens is, the whole goal of the menstrual cycle is, starts out, cleans everything out, old tissue, right, menses. As soon as menses is over, that endometrium starts growing again, if the patient's not on hormone therapy to suppress that.
Yeah, that would have been nice.
Well, we can put on our paper that no one has hormone therapy.
I thought it was that other thing
Well, I
that
do.
she was talking about.
Well, birth control is estrogen and progesterone. Couldn't get the P. I don't know why I wanted to say pro something. Progesterone, I knew the pro was there, but I couldn't remember the back part of it. So, basically what a birth control pill does, it makes your body think you're pregnant. So that we don't have luteinizing hormone. What does the luteinizing hormone do? It starts up here, yeah. What now?
It calls the ovaries to start getting.
Okay, so it's gonna kickstart everything, right? Luteinizing hormone kickstarts the whole process, all right? The ovaries, follicular stimulating hormone, what does it do? That's pretty obvious.
Stimulate.
Okay. So during the luteal phase, there's a luteal phase and a secretory phase. The luteal phase is just getting everything kick-started again, starting the process over. Okay? The ovaries will respond to that follicular stimulating hormone and start making little follicles. The follicles produce what? Estrogen. Okay? The estrogen tells that endometrium, hey, go to town, proliferate, grow. Okay? And then at ovulation, the luteinizing hormone kicks in really heavy, boom, and the follicle that's decided to be the dominant follicle is gonna and ovulate. Okay? Well, that follicle, now that it's ovulated, it turns into what? The corpus luteum, and it produces progesterone. Okay? The progesterone is saying, let's not have menses yet. Hold on. If there's no conception, progesterone, menses happens, starts over again. Okay? I would think of that little song, stop in the name of love. Okay, that's what progesterone does. It halts menses, stops it. Okay? So think about, just giving you a brief run through of that. Think about the patient that comes in. Maybe they've been, they haven't been able to have a baby. They've been trying to conceive. Okay, we ask them, okay, when do you remember the first day of your last normal menstrual period? If it's somebody trying to have a baby, they remember. I promise you, they will remember. They're about the only ones who do. Okay, and maybe she says that it was 3 weeks ago. Where do you think we should see her? Maybe, let's not say 3 weeks, let's say 2 weeks ago. What do you think we should see when we're looking at the uterus? That's what y'all are trying to put together when you're studying repro. If you don't know where they should be, if everything's normal, then you won't know where to go from there.
She should be ovulating.
She should be right at ovulation or almost at ovulation. So her endometrium should already be past that 3-line sign, and everything should be starting to get more echogenic. Maybe not super thick, but the whole thing is echogenic. Because we have that basal layer of the endometrium that never sloughs away on each side of that lining. Because it's just a cavity. Each line, the whole cavity is lined with that basal layer of endometrium. Okay? When it starts growing a fresh new endometrium, it's hypoechoic. It's baby endometrium. Where those 2 baby layers touch is another white line. That's the 3-line sign in that early proliferative phase. That tells us, like, say you're scanning somebody, they're, between a week and 2 weeks out of menses, you expect to see a 3-line sign with some fresh little hypoechoic baby endometrium. It's just little sweet endometrium. Okay? If they don't have that, maybe, or think about this, maybe it's that person that comes in and they say they're 9 days ago, 10 days ago they had menses, and their menses lasted 5 days. Okay? And their endometrium is a centimeter thick and it's bright white. Is that normal? No. No. They can have what's called hyperproliferation of the endometrium, meaning that endometrium got thick even when they had menses, though it never sloughed away. It's old endometrium. Decrepit endometrium. It's not functioning properly. It can't support a baby. Because it's like beyond usable. That's a huge sign to the doctor. Maybe they don't have maybe we've been following them, they never have a Graafian follicle. Maybe they just have a little tiny follicles kind of around the periphery of the ovary. The ovary looks kind of round. That's polycystic ovarian syndrome. They could be having anovulation because their hormones are like crazy. Okay, so the doctors can give them some different hormones. They can do a DNC, dilatation and curettage, where they dilate the cervix, go in and scrape out all that old tissue to give them a fresh start, a little zap of some hormones, and they can get regulated. It's not okay. It's really pretty complicated. But that's our job, though, is to say, hey, according to her last menstrual period, she should be here, and it looks like that. So when you're studying it, think about what normal should be and what we can see at specific times, and go from there and give your impression. I expected to see a thin, proliferating endometrium, and I see this big, thick stuff. That makes more sense when you think about the physiology of it. That's the why behind, well, who cares about a 3-line sign? Okay? We really care if that mom is trying to have a baby. Okay? Or maybe she's bleeding like a stuck pig all the time and she's anemic. We care what it looks like, because what we tell them could indicate, hey, the doctor's like, by this finding, we need to do a DNC to help you. Maybe she has a polyp, okay, or fibroid pushing up against her endometrium that's aggravating it. What kind of fibroid would that be? Remember the three names? What we call them? Think about the layers of the myometrium. You know, remember the three layers of the myometrium? Okay, not of the uterus. Okay.
Functionality stays loose.
Louder?
Function.
Okay, that's of the endometrium. So the myometrium muscle itself, okay, we have the outer cover, serosa. That's where the peritoneal lining. We have the actual myometrium itself, and that hypoleucoic ring you see before endometrium, that's the innermost layer of the uterine muscle, the myometrium, called the mucosal layer. The doctors are going to want you to identify, is it a mucosal fibroid, a subserosal fibroid, or intramural fibroid, or pedunculated fibroid, okay? The mucosal fibroid can push up against the endometrium and aggravate it and cause all that bleeding. Pedunculated probably never caused a problem at all. So when you're studying it, that's the kind of, I'm trying to think, the thought process you want to think of when it says, okay, in this book where it says sonographic appearance.
Yeah, we need to know how relatable to,
Right.
what, I mean, right now we're just going in there going, okay, what do we have to test on?
Yeah.
Did I get that right picture? But we're not really learning why
Right.
it is we're getting this. And that's,
Right, so just for instance,
Yeah.
on page 193, I'm just trying to, I'll read it to you. Talk about the portal venous system. Okay, it says you can clearly see it, it tells you where. Okay, if it's possible, show that splenic vein coming into the main portal. Okay, portal veins become smaller as they progress into the liver. Remember me telling y'all that? That's why I wanted y'all to lengthen it out. If this was the liver, a lot of you showed me a portal right here. Remember I said that's really not the part we want to see because the liver is confining it. If it's dilated, it's not going to dilate there until, like last, I guess. It's the portion out here that we're going to notice the dilatation. So you want to lengthen it out. So that kind of thing right there tells you, it says, okay, what did I read? Just a minute. Oh, I got close. So I couldn't find it. What did I say? Thank you. Okay, so I'm looking under that second column where it says sonographic findings. Okay, the last paragraph, portal veins become smaller as they progress into the liver from the porta hepatis. Large radicals situated near or approaching the porta hepatis are portal veins, not hepatic veins. Okay, so that tells you any vein that has anything to do with the liver, that's outside of the liver first coming in, that's a portal. Hepatics are in the liver only. Well, do you think that's huge to a budding sonographer? So I know it is all confusing right now, and I know there's so much being thrown at you, but try to digest little nuggets like that. Maybe when you read, especially these sonographic findings, sonographic impression text, like after you try to learn about something, kind of read through that and say, what does that really mean to me? Would I be able to see that? If you don't know, come ask one of us. Maybe put a little star by that, but this is going to help me because I'm going to know. Okay, so if the portal was the exact same size extrahepatic as it was intrahepatic, are you going to be so worried about it? You just learn that they're smaller once they get inside. So if it looks the same diameter all the way, you don't have to worry about that portal. Does that make sense? I mean, unless it obviously looks big. Maybe it did finally get big inside. If it looks big, we throw calipers up there. Because it'll tell you in the text, it shouldn't be over, I want to say 12 millimeters. Is it 12 or 13? okay? And it'll continue to tell you that if it does look dilated, that extrahepatic portion, you're gonna get them to bear down, like they're having a bowel movement. Just do that valve maneuver and bear down. If it stays dilated, it's truly dilated. We'll put color flow on it. Which way should the blood be going? Into the liver. So another thing you want to do, knowing what you know about color Doppler, is this angle going to be reliable? Straight across the screen to show you the blood's going in? You got to angle it. Okay? The best way to angle it, the portal's on this oblique. Stay in that oblique, but come over here. Look at that portal. Isn't it pointing right at my 10 Pro? Okay? So when you do that, now the portal will look like it's coming in this way. Now will color be reliable? So what color should it be if I put color Doppler on it, if it's normal?
Red.
Red. Okay? If I put pulse wave on it, and that's the baseline, who cares which way the stick is? If I put pulse wave on it, should it be below or above? Should be above. Okay, antegrade. It's really kind of straight like that. All right? If you angle it up toward the probe, and you have it inverted or anything, nobody can question your findings. Okay? If it were blue, it'll probably more than blue, it'll be turbulent because it's trying to go in and out. Okay? If it's completely closed, it'll be, you might have some that's still getting in. That's what I'm trying to say. But if you show the portal lane coming up with your color, and it's blue, and this is retrograde, then that is hepatobutyl. Okay? So the thought process behind, why am I taking this image? You need to try to glue those things together. And it's, like I said, you're going to get more doses of all of this again and again and again. This is not the only quarter you're going to learn about portal. Okay? You're going to hear it again. Well, actually, you're not even supposed to hear it this quarter. But you got a little piece of it probably in anatomy, right? Yeah. So don't freak out. It's called growing pains. There's no way you can know it all right now. I don't know it all. Miss Bandu doesn't know it all. None of us know it all.
Miss Crampton.
Close. Out of all of us, she's close. She's a smart cookie, but gets too tired. No, she was smart before I ever met her. Anyway.
I asked her, do you have a photographic memory? She goes, I've been told that. I was like, yeah. I'm surprised she wasn't like it, I did it.
So, that's, like I said, we're not super following the chapter, but most of this, chapter 7 is so almost redundant because it's stuff that you already looked at.
Like anatomic conditions.
Yeah, but, I mean, all that's hugely important. Like I said, the biggest takeaway is start trying to piece things together and answer that question. I tell people, when you're studying, try to answer the what, the where, the how, the why. What, where, how, why, what, where, how, why, what, where, how, why, for everything. You can add lab values too. What, where, how, why, lab values. But if you can answer that for each organ in each image you take, there's a what, a where, a how, and a why for every image we take, or we wouldn't be taking it. Okay? And if you know, when you're starting to study pathology and really get deep into it, if you know the why would an echogenic kidney be an issue? Why would I even care if I saw an echogenic cortex? You're going to learn the why. There's lots of reasons. Those are called differentials. It could be this, 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 or this. We just know it's echogenic. Okay, we might be able to get a little more, narrow it down by different pieces of the puzzle that we are privy to. But, anyway, gosh, we don't know, like on the third slide. Metabolism, of course, that is what the, our whole body is about. The liver is the biggest metabolic functioning unit we have. It's like the first stop for anything we ingest. After it's absorbed into the circulatory system, goes through that portal veins, gets dumped in the liver, and the liver has to decide what to do with it. Good, bad, keep, save, get rid of. Make this out of it. Store, secrete, do whatever, not really secrete, but you know, like put it in the bloodstream right now. The liver's deciding what to do. Be nice to your liver. Really need it. I mean, luckily, it can regenerate somewhat. Okay? Our livers are amazing, but be good to them. I had a patient one time, I might have told y'all this, it's just always just burned into my memory. He was only 35 years old, dying of cirrhosis. He was in end-stage liver failure, okay? So his liver had necrosed. It was like hard, echogenic, tiny, abdomen filled with ascites. And this is what he told me, and he had not, I mean, he didn't drink anymore, but he still smelled like alcohol. He still smelled it. It like comes through the pores, like a sour, sweet sour smell. You'll know it once you smelled it a few times, and you'll expect that liver to be lit. Okay? He said, you know, doctor told me if I just drank that clear whiskey, or the clear stuff versus the dark stuff, I probably would have done this. And I'm thinking to myself, just don't drink at all. I know, but I know, that was what hit me. I'm like, you killed yourself. Of course, I didn't say that to him, but it just ripped my heart out when he said that, thinking, you're a baby. In the big scheme of things, 35 years old. So anyway, be good to your liver. Just side note. Be good to your liver. Okay. So, the liver's biggest job is to keep what we call homeostasis. And you know, that's a balancing act, okay? If homeostasis is not there, you start getting sick. Patients start showing these signs and symptoms. So we have to try to help the doctors figure out what's causing it. If the liver function tests are out of whack, it's either a disease process or an obstructive process. One of the two. Either the liver cells, the hepatocytes themselves are sick or upset, or the bile trying to get out can't get out. Okay, we look for jaundice, things like that. That tells us that homeostasis is not being kept. And something's wrong with the metabolic processes that are going on. Okay? Other metabolic processes, it says maintaining operations of nerves, muscles, and other body parts. So when one organ system starts breaking down, like I said, the liver, the spleen can try to take over for it a little bit, but there's just so much it can do. So if the liver is sick and dying, we would expect the spleen, like I said, to take over. Blood would go out and go to the spleen. The spleen gets bigger because it's taking on a bigger job, okay? And there's extra blood vessels trying to relieve that pressure, because that blood's going with force into the liver and it's turning it around. Extra little blood vessels grow everywhere, around the esophagus, towards the spleen, around it, around the hilum of the liver, and the hilum of the spleen. Those are called varices. We have to know to look for those. So, knowing, what did I say, the what? The where, the how, and the why.
And the lab result.
And labs, your labs help too. And you don't have to necessarily memorize labs, y'all. I never memorize them. I always get my book. Because the good thing about it, if you're pulling up somebody's labs on the computer, it'll say hi. Hello. So that's really good. Amylase, lipase, all the ACEs, or go with the pancreas. If they're elevated, you know, something's wrong with the pancreas, right? So, I never committed to memory. You're recording this, aren't you? That's okay. I really never committed to memory. Now, your teachers might make you, But I'm talking about in the real world, when you're working, you look for those highs and the lows. If you forget that something, this is low, look up. Can you commit everything in this world to memory? We're not Miss Brown. So don't sell your books, keep them. Invest in something like that that's, going to help you, because you can't remember it all. But know how everything affects everything else. Oh, homeostasis, look. Yeah, jump it down. Okay, so it's the same life. There must be a homeostasis. Like, if we lose enough water, we can actually die. If you get dehydrated to a certain point, okay, it can kill you. And be careful, if you got elderly, like grandparents and stuff, keep an eye on them, especially if they start getting dementia, they forget to drink. Okay? And once an elderly person gets dehydrated, I know from my grandmother, they can get dehydrated again really easily. I don't know what it is about it. I kind of think, I'm not trying to say grandparents or old people are like plants, but have you ever, listen, have you ever let a plant get really dry? But the soil just dry up, oops, I forgot the water. That sucker, you never can get that soil to plump back up and stay wet. It's in my experience, I don't have a great thumb. But I kind of think about it that way, because like once they get dehydrated, and anybody, pregnant women too, be careful, make sure that they're staying hydrated, because once you get dehydrated, it's really easy to fall right back into it. So, but it's huge. If we don't have enough, like I know when I haven't drank enough non-caffeine or bad stuff. If I drink too many Cokes, whatever, I'll wake up in the middle of the night with leg cramps. Thinking, oh, I didn't drink any water or anything good for me today at all. So stuff starts happening when homeostasis is not met, right? Okay. Vital signs, we've already talked about that. We know that there's a nice normal range for the heart rate, for breathing. Okay, what is when somebody hyperventilates? What's going on? Think what hyper means? Too much. Ventilation is
Breathing.
so they're actually breathing too much. They're hyperventilating. Okay? We need a homeostasis. We need that natural balance. So that's why you have a break through the plastic bag. Oh, not plastic bag. Paper bag. Got to get air in somewhere. Don't do plastic. Sorry. Paper bags, air will go through it. It's so they don't get as much oxygen. You can kind of reverse that hyperventilation. Okay? So, death is the absence of vital signs. Yeah.
I can remember.
Yeah. Well, when my kids were real little, if something or somebody died, like a dog or a family member, anything that has a heart, instead of trying to, well, Aunt Betty died because she had leukemia and it did this, her heart stopped beating. Everybody that dies, the reason they die, actual death itself happens, is their heart stops beating. Now, there will be things that cause the heart to stop beating, whether it's old age or a disease process, but death itself is your heart stops beating. And they could live with, I didn't mean that was a pun, I didn't mean to. They were okay with that explanation. Okay? It's funny, my son used to say beeping. Is it beating? Beeping. Beeping. He'd see something like garbage on the road. His heart stop beeping? Yes. After the car killed it, yes. I didn't really say that. Did its heart stop beeping? Yes, it stopped beeping. Anyway. Now we're to the stuff down. The anatomic position is huge. Okay, you gotta know. So again, this is telling you universal orientation. It's like if I'm the patient and I'm standing looking at you with my palms this way. Any imaging modality you're going to ever look at will be based on that. So like Jessica, that's her right eye, that's her left eye. So that's a hard hurdle to jump when you're scanning, is you're going right, but that's their left. You're going left, that's their right. So just be careful. we're getting that down. When you start scanning OB next quarter, y'all, if you have to, close your eyes and put yourself in that baby's position, do it. Because that orientation. Yeah, because that little sucker can move. So you're going to go based on a survey of mom's anatomy, straight up midline, perpendicular to her body, scan through the uterus. And if you scan through the uterus, just give you a little quick open lesson. If you scan vagina, then you see cervix, and then you get to uterus, so here's the myometrium. Guess what? It's big because it's got a baby in it. So that's myometrium. If you were to see, this does not work. Okay. If you were to see, I did a backwards, wait a minute. What we call 3 ossification centers of the spine. It'll look like that. 2 longer white bones, like this, and a round one. 3 white dots. This is mom's, I'm scanning transverse now, so this is mom's what? Okay. This is mom's left. I'm transverse on her abdomen, and I see the baby's spine on her. Okay. Maybe I started at the cervix and saw the baby's head. So that's what I'm saying. I'm going to stand like I'm y'all scanning. I'm going to put myself in that baby's position. Okay, my head is towards mom's feet. My spine's on her right, so I'm laying like that. Y'all with me? You have to do that. Because who likes struggling, banging their head up against the wall, searching for a needle in a haystack? Anybody enjoy that? Anybody? Anybody? Okay, we got that narrowed down. We decided we do not enjoy that. So I'm telling you, with OB, orientation is huge. You got to figure out where is that baby laying. So if you're here and you wanted to get back to the baby's head, you would go toward mom's feet. If you want to get toward its legs, you go toward mom's head. You got to have that mental picture which way that little sucker's laying. We have baby dolls in the lab to help and kind of hold it up if you don't want to do the, you know. But I had to close my eyes even when I started work. So I worked in a radiology department. I didn't scan OBs every day. Just give me a second. No, just yeah. You have to figure it out. So huge. Y'all, anybody confused with any of this stuff? Be honest. So good? Awesome. The medial and the lateral. Let's talk about that for a second. That's based on, this is my midline. Slice me like a hot dog bun. That's the medial plane, midline. Okay? That can be the global, the orientation. So if I'm going lateral from midline, I got to decide, am I going right lateral or left lateral from midline? Okay? If you're talking about an organ specific, say I've got kidney here and I want to go to the medial side of the kidney. I've got to decide which kidney I'm on. If I'm on the right kidney, medial is toward the midline. Left kidney toward the midline. So it's opposite directions, but it's all toward the midline. What's closest to the midline? Thyroid, medial is this way. If it's this thyroid lobe, lateral is out. Some of y'all got told the wrong thing or confused or something, but if you're on the left thyroid lobe, this way is medial, toward the trachea. Medial for thyroid is always toward trachea. Lateral for thyroid is always toward carotid. Okay? So that, you know, is one thing that can be a little confusing.
The only thing that confuses me about that, I know we gotta go, but AP of the ovary, like anterior posterior measurements of ovary.
Okay.
Measure
The ovary, anything that's oval. Okay, the ovaries are oval, so that means they're rounded, but they're longer in one plane. right? They're oval. So, scan, find the longest length. Whether you're doing kidneys, ovaries, it doesn't matter. You want to measure, it's pretty oval, you want to measure down the long before you do the anterior posterior. Let me do this. So find that longest length. If it's tilted on your screen, then it'll be a measurement like that, right? If it's tilted, you just go with it. And then from that long that you measured, you want to find the widest point and measure perpendicular to that long measurement. So again, if it's tilted, that measurement will be tilted too. But you base it on what you did for long. That's the AP, perpendicular to the long. Does that help?
Yeah, that's simple.
If you'll always do long first, AP is just going to happen. Okay? Now transverse, since we're talking about ovaries, it's a pet peeve of mine if you ever do one for me. When you go transverse, they're usually pretty rounded. Okay? Transverse, I'm going to make it kind of oblong. Okay? Transverse is right to left through the biggest portion on your screen. Okay? So you don't want to do that. If it's laying like this will be the biggest portion. Right to left. Right to left. No oblique stuff. If you don't like it that little stuff lays kind of funny and transverse, rock your probe and flatten it out. Measure right to left. Okay, that's a pet peeve of mine. In that dimension, you're not finding the longest piece of it. Okay? You want to go right to left. Even when you start measuring first trimester OBs, you'll be measuring the sac that the baby's in. It's called a gestational sac. It's black and it's fluid filled. You'll find it in the long plane. You'll measure the length. You'll measure the AP. And in trans, you want right to left. You don't want another AP. Because in transverse, AP is this way. In long, AP is this way. AP is AP. You've got to have the third dimension that you haven't done yet. Does that make sense? Okay.
And you know how twisting stuff up
Right, it's transverse, you want to go right across it. Okay? Let me just flash them, make sure I have it. The rest of it is that stuff that we've already gone through from day one, basically. Okay, real quick, the cavities, y'all know the retroperitoneum and the peritoneum? Okay, think about it this way. What you see right there on Fred, all of that is retroperitoneal. The great vessels, the pancreas sitting in here, but the great vessels, the kidneys, that's retroperitoneal. So everything that's anterior to that, toward the belly, toward the ventral side, it's completely wrapped in that peritoneal cavity, like cellophane's wrapping it up. That lays under the cellophane. We call it peritoneum.
Well, remember I found that thing, that had all
Okay, visceral. What is a visceral organ?
What organ?
I can't hear y'all, but any organ covered by peritoneum is a visceral organ. Okay, so kidneys are not visceral. Okay, the lymph node chain is retroperitoneal. And what's important about that is you want to know, okay, because of the peritoneum and the way everything lays, we've talked about this, Morrison's pouch, okay, there's a potential space for fluid there. Any fluid in Morrison's pouch ever is not normal. It's a little bit of fluid in the cul-de-sac and the pelvis, that's physiological, that's not a big deal. More than a little bit is not normal. Okay? So that's the biggest thing about the peritoneum. And knowing, the potential spaces to look for fluid. Okay.
So what are we supposed to be?
We're gonna go, we'll CPR in. I'll go get stuff.
In here? Oh, in here.
Yeah, we can do it in here.